And the next speaker to take on is Dr. Mohammed SHAHBAAZ, who's a senior consultant cataract, cornea, and refractive surgery from the Eye Foundation Group of Hospitals, a very dynamic, versatile surgeon from Bangalore, and he's going to show us a very challenging moment. On to you, Dr. SHAHBAAZ.
Thank you, madam.
Yes.
Video is clear to madam?
Yes, it's clear.
Yeah. So this is the case. You can see this is slit lamp video which I have done, slipping down. And on table, you can see it is floating on the anterior vitreous face. So I have a plan to do a phaco with IOL with a Sionis ring. Now, when I try to check whether vitreous is there in anterior chamber or not, lens get tilted. So I'm using a high density viscoelastic to push it back. Now, the rhexis is very, very difficult in these cases. You cannot, as you try to pierce the cystitome, it will dip down. So this is a bimanual rhexis which I am doing. One-sided, I am holding the rhexis margin, and with the other microforces, I'm just completing the rhexis. For making opening also, I did the same thing. So once the rhexis is done, now half of the work is done. Now, next thing is to put iris hooks. Again, the iris hooks, you have to hold the rhexis margin with the microforceps, because once you try to dip, the whole lens will dip down. And then this is what I do. I separate the cortex from the capsule. And this helps in placing the Sionis or CTR ring without entrapping the cortex. After this is done, this is the Sionis ring. Though I'm not very happy with large open Sionis ring, but this is what are available nowadays. And while putting the Sionis, you have to put additional iris hook, because it itself, because of the torsional or rotational force, it is trying to dislodge the other remaining zonules there. So I put another hook, and then somehow I'm able to put the Sionis inside. Now this is my technique. I just hold the Sionis. Once you hold the Sionis, the lens back complex becomes very stable. People is fully dilated because of the traumatic mydriasis. Now the rotating of the nucleus becomes very difficult in all those in these cases. So I just remove one pie from one side. Then this is very slow process. We have to keep on injecting visco in all the quadrant to dislodge the nucleus. The cortex are adherent to the capsule. But because of the visco, we have separated it with visco. The whole cortex and nucleus has come in one go. A small amount of cortex was there that I have removed. Now the implantation of IOL, in the whole video you have seen, the lens back complex is very much stable. It doesn't look like the subluxated cataract. That is just because of this Sionis is held by the iris hook, not because of the iris hook per se. Because when you are doing only iris hook, the lens back complex, like it's flip-flops. And this is very important. Whenever you are passing a sharp instrument inside the anterior chamber, you have to give support with the spatula so that you do not go and hit any. So this is what we are going with a spatula behind the sharp needle and then passing the needle inside. This is very low technique, I think most of us have. And then the tying is very important. If you tie too much, definitely it is going to go in one direction. But even if the optimal tying, the lens is subluxated in this case. I'm trying to bring it in the center, assuming that this side, the zonules are intact, but it is not. So I plan to do, I was not having Ahmed segment at that time. Otherwise, segment itself is sufficient. So I just put another Sionis in this. And I tied from both the sides. This was the post-op picture. One more thing I would have done is a pupilloplasty, but it becomes very long surgery, so I didn't do.
Thank you. You can stop sharing. Thank you, Dr. SHAHBAAZ. That was a very challenging video which you showed. I'll take the first question with Dr. Gaurav. Gaurav, you're there? Yes,
I'm
Gaurav.
there.
Now,
Yeah.
with this kind of gross subluxation in the present day, would we do all these gymnastics, or would you go straight for a, SFIOL, blue diol?
Ma'am, actually, cataract still has to be removed anyway. And,
Yeah, yeah.
a controlled cataract removal, if you had to go straight for an SFIL, maybe one thought would be to go for an intracapsular, but then you'll be opening the whole chamber and stuff. So I think doing the phaco bit is going to be essential. And he very nicely demonstrated that technique of, kind of to stabilize the bag, because the bag is so mobile, the lens is so mobile, to stabilize it with a bimanual technique and, complete the rexis. And, he was using some very nice forceps, but similar to this are the micro graspers from MST, which you can use, which will, also hold the capsular bag while you attempt the rexis with the second hand. So I think that was a very good take-home message for people who are dealing with subluxated cataracts, and can be done to help get a good rexis. But I feel that he did everything so well. The only thing I would have done differently is to maybe put, instead of the iris hooks, today I don't like to use iris hooks because they end up causing rexis break sometimes if you're keeping them tight. He was doing it very deftly, so I think he got away and did a great job. I would have put capsular hooks, because then it becomes easier, because it not only does not injure or break the rexis, but it also stabilizes the equator of the bag, because they are expanded at the end. So you don't need to put CTR till much later. And even Sionis ring and or MS or these segments like MS segments can be put later on. If you have 4 capsular hooks in place, the bag remains kind of supported at the equator, and the timing of the CTR can be delayed, or the Sionis ring. Otherwise, everything was done very well.
Yeah, and he anyway said that instead of a second Sioni, you could have put a CTS Ahmed segment, would have made sense. And of course, pupiloplasty is indicated.
And very
Anaga,
innovative way of
this
putting the
maybe
iris
which
hook.
thing we
to
could
support.
ask at this point of time, Anaga?
Only one point is there when we are even using iris hooks also, sir. Instead of capsule hooks also, the posterior capsules are still flabby. So when at the end of surgery, the capsule, like we have done everything perfectly, but at the end of the surgery, the posterior capsule comes in the phaco probe. So that is one.
At some point, you have to put the CTR anyway. So you can only delay it a little bit.
This is what, like if you put a ring in before, and this, if you create a space, you can very well easily put the CTR.
Yes. Any of the expert panel have anything to add? We can go on to the next.
I would agree with you, Chitra. Right in the first go, I'll give some work to the posterior segment guys.
Yeah, true.
Rather than testing, because see, they can easily use a phaco frag, Gaurav. You don't need to do an intercap or whatever it is. They can easily do a good vitrectomy, do a phaco frag, because he did an excellent surgery, but for mere mortals like us, it may not be very easy, though it looks very nice for presentation, but majority of the people may not be able to do it. It's more time consuming, and it's you tying sutures, this, that, and the other. The Yamanes or the glued IOL, all these techniques that have come are really very, very good, and now they have long-term follow-ups. So I would, if I see such a case with so much, and in any case, the cataract was not too hard. So I would straight away ask my posterior segment people to do that. Also reduces your work and your blood pressure remains better.
Yeah. But great video, SHAHBAAZ. Keep it up.
Ma'am, can I put a word, please?
Yes.
SHAHBAAZ, it was an excellent surgery. I don't think so. You people are very fond of retrofixation of iris claw lenses.
That's another one.
Yes.
And it becomes very simple. Even you don't need a pupiloplasty. You can just pull on the pupil and it works very well. Only thing is you got to plan before and make a sutureless tunnel for the lens to go in before proceeding with the phaco in this case.
Dr. Chitra does very good iris supported IOLs.
Yeah, Dr. Ramamurthy is very fond of.
Look at him.
But these iris are already fibrous. If you try to pull, definitely the lens will not hold. It will cause tear in the iris. Anyway.
No, there are different thoughts to how you could skin the cat. So you are with